Be great. Thank you. And I will turn it over now to Barb Chopey. Barb.
Hi, everyone. As Greg said, my name is Barb Chapey, and I'm the president of the Physical Therapy Learning Institute, and I have the privilege to welcome you on behalf of my board colleagues to our inaugural PTLI Disruptive Innovation in Physical Therapist Education Summit. Our theme for this year's summit is Reimagining Physical Therapist Education. The board is really honored to have each of our invitees join us as we welcome our presenters and engage in lively dialogue that most likely will bring differing opinions over these next couple of days. You might ask, why was I invited to this summit? Well, each of you were nominated by one of our board members as a recognized leader or as an emerging leader who represents the academic and clinical community of our profession. And more importantly, you're known as someone with creative ideas who is willing to explore and act on opportunities that ultimately can shape the future of our professional role identity as physical therapists. Greg, can you advance? I want to take a few minutes to highlight some of the PTLI initiatives that illustrate who we are and who we aspire to be as nimble yet impactful organization of the future, and share our excitement about today's summit that has been in the making for over a year. PTLI was founded by two visionary leaders in physical therapy, Dr. Geneva Johnson, known by many as the Dreamer, and Dr. Linda Woodruff, known as the Doer, who, as dear friends, originally envisioned PTLI as a think tank outside of the traditional space of our formal association and special interest groups. We are proud to be continually evolving in a manner that honors their amazing contributions and legacy as our founders, while we open new doors for the future. Jeannie is honored each year at our annual Geneva R. Johnson Forum on Innovation in Physical Therapy. That serves as the keynote address to the Ed Leadership Conference held each October. We also look forward to hosting the second annual Linda Woodruff Lecture on Diversity, Equity, and Inclusion in Physical Therapy that is scheduled for June 17th, 2021. That was Linda's lifetime passion before her untimely death in 2019. Check out our website for more details on both of these, as the forum is in our 8th year. Next slide. This brings us to a place where we see ourselves as a small group of action-oriented, non-traditional influencers, collaborators, and drivers of change with big ideas at one of our most recent Zoom meetings. We're very excited to host this inaugural summit, as we expect it to become the annual event and be our third pillar in our portfolio. We're committed to offer forums, lectures, and summits like these that bring individuals together within a safe environment to explore ideas that challenge the status quo and foster innovation, collaboration, and action to ignite change and to advance education, research, and practice. And today we welcome each of you as you join us in our journey to influence and shape the future of this great profession. Before I end my welcome, I want to share a quick update on Jeannie, who is now 98 years young. I had an opportunity to FaceTime with her earlier in the week and to update her on our plans of this summit. Her smile and her encouragement, as she said, "Make it happen," was endearing, to say the least. But best of all was the story that her niece shared with us. So last week, as many of you know, Jeannie lives in an assisted living facility. They had an in-service for all of their aides on safe lifting and walking assistance that was presented by two physical therapists that serve the facility. Well, the training was held in a large sitting area that's directly outside of Jeannie's apartment. Her caregiver, knowing that Jeannie was a physical therapist, thought she might enjoy listening in, so she gave her a seat outside of her apartment and offered her a handout as well. So she sat patiently. Well, when they announced that the session was about to begin, Jeannie rose to her feet, pushed aside her own walker, and proceeded to the front of the room with her index finger pointing and waving away, telling the physical therapist that she was going to show them the right way to teach these aides to safely lift and guard her friends. Well, everyone was in shock and in awe, but Jeannie continued to offer a few suggestions to the group, and then she politely turned around and went back to her seat. Well, after the session, the supervisor, she was just appalled, and she really apologized to the physical therapist for the interruption and shared that Dr. Johnson was a physical therapist. Well, one of the young men, who had no idea that she lived in the facility, said, "Is this the famous Dr. Geneva Johnson?" Well, when he received that affirmation of yes, he shook her hand and shared how honored he was to personally meet her. Well, she smiled, let him give her a great big hug. And then, with a great deal of pride and change in her posture, she let the aide guide her back to her apartment. So after all these years living quietly in her apartment, Jeannie is now the talk of the community. Well, I do hope that this update gives you and gives us all the motivation to continue to lead with passion, persistence, and patience, as Jeannie has done throughout her 75-year career as a physical therapist, a teacher, a mentor, and a friend. So again, welcome, and let's make Jeannie proud. It's time to turn the summit over to our planning chair, Greg Hartley.
Thank you, Barb, and welcome to all of you. We have invited you all for a reason, and we hope to really engage you in important and stimulating dialogue. For many years, there has been a robust and ongoing discussion related to excellence in physical therapist education. Recent conversations around the return on investment for education in this profession, post-professional residency and fellowship education, workforce issues, DE&I, and most recently, the pandemic, have escalated the conversation and required institutional action to reimagine physical therapist education. This virtual summit is intended to stimulate deep conversation and foster action among invited attendees to address both anticipated and unexpected opportunities for change in physical therapist education. The time for change has arrived. And now, without any further ado, let me turn the floor over to Dr. Gail Jensen, who will do us the pleasure of introducing our keynote speaker for this evening.
Thanks, Greg. This is such an honor for me. I've been following Dr. Cutter's work for some time. So I'm going to have two parts here. I'm going to start with the kind of traditional standard biographical information about Dr. Cutrer, but then I have some additional comments I want to make about him and his work. So Dr. Cutrer is he's an associate professor of pediatrics and critical care medicine. Also, he's the associate dean for undergraduate medical education at Vanderbilt University School of Medicine. He received his MD degree with high distinction from the University of Kentucky College of Medicine. And that's where he completed his pediatric residency, chief residency, and critical care fellowship at Baylor College of Medicine and Texas Children's Hospital. He also holds a Master of Education degree from the University of Cincinnati, which you can see how it's influenced his work. Dr. Cutrer is an exemplary clinician. He's a skilled administrator and an education researcher. Through his associate dean role at Vanderbilt, he leads innovation. He probably has done some disruption, I think, in medical education, including curriculum development, student assessment, and program evaluation. His ongoing work and publication record provides an impressive view of just how influential his work is, not only in medicine, but for other health professions like us. So my first connection with Dr. Cutrer was his 2013 paper on educational strategies for improving clinical reasoning. And that he had in there a model of conscious competence model, a 2x2 table. It's a great paper. It's a great paper for teaching clinical reasoning. He co-led the AMA's Accelerating Change in Medical Education initiative on the Master Adaptive Learner Working Group. That led to his primary authorship of this, what I call a classic paper in academic medicine. And we cited this a lot in our work, Fostering the Development of Master Adaptive Learners, a conceptual model to guide skill acquisition in medical education. And he's also the lead author on the 2020 book, The Master Adaptive Learner, which I say everybody needs a copy of. And Unfortunately, if we were face to face, he could sign it for us. And that's part of the AMA Medical Education Innovation Series. But what's visible in Dr. Cuttrer's work and writing is his clear commitment to learning, particularly how students learn, how they learn in the workplace, and what can be done to help them develop as adaptive learners towards adaptive expertise. His research highlights the critical role of facilitating the development of adaptive expertise in our learners, that they're able to not only respond, but to innovate, to practice challenges. He's published and presented widely on topics central to questioning and facilitating change in medical education. I've looked his recent papers. Let me just give you a couple of examples. Building learning communities, a course on framing medicine as a moral practice, medical student portfolios, and the need and role for a systems view of stakeholder development in meeting the demands of EPAs. At Vanderbilt, he leads a core team that's participating in the AMA pilot project, core and trustable professional activities for entering residencies. Vanderbilt has what is described as a responsive, agile system of lifelong learning designed to prepare students to respond to a rapidly evolving healthcare system. And here are my last comments. Perhaps most important is his combination of deep commitment to learning for all health professionals. His keen intellect is coupled with this willingness to share his time and talent with other health professions. He's a great guy. We are thrilled to have him here to challenge us this afternoon and engage us in disruptive yet innovative conversations. So please join me in welcoming Dr. William Cutrer.
Wow, Gail, I only wish my family could have been on here to hear all of those lovely things you just said about me. Now you've set the bar really high. I don't know that I can live up to that, but I will try. It is so much fun to be with you all. I'm really excited that we get to spend some time together here today. And I do hope that some of, at least one thing that I say will spur on some of the conversation and the disruption for you all. Even in the 10 minutes before this all started, talking with the planning committee was just exciting and energizing for me. It was exciting. So I'm really excited to be here. I look forward to diving in. With that, let's get going. They did give me about half an hour or so to share some ideas, and then we'll do about half an hour of question and answer. So if there are things that you want to talk about related to a slide, related to Vanderbilt curriculum, happy to talk about all of it. I can't follow the chat on my small screen, so if there is something that pops up in there, I ask the Gail or Greg or one of the others to follow that, and I can see about 4 or 5 of you at a time. So please feel free to smile and nod along, but really, this is gonna, I hope will be fun. So disclosures, I don't have any disclosures, any conflict of interest. Gail did mention that Vanderbilt has been a recipient of the AMA's Accelerating Change in Medical Education grant, and I was part of that. I don't get any proceeds from the book. I don't get any direct funds, so there really is no conflict, other than I'm biased, and I think it's actually a very powerful model. One other disclosure, she mentioned that I'm in pediatrics, so I'm a physician that works in the pediatric intensive care unit. And so some of my experience, some of my stories come from there. But that said, the topics we're going to wrestle with today, I have talked with our nursing school to help them think through some of these ideas. And regardless of the health professions, any individuals that I've spoken with, it seems to resonate. And so I hope that that is true for you all as well. And lastly, before we dive in, I have tremendous respect for you all as physical therapists, both because of the shared patients that we get to take care of, and you provide amazing care for them, for the patients that we share on our team, as well as just myself. I'm a runner, and I'll tell you, I ran no marathons in 2015 and 3 in 2016. And as you might imagine, I needed the services of a very friendly and expert physical therapist for some tendonitis after that. So I have tremendous respect for what you all do. All right, so I want to start by thinking about a gap. And I want you to help me think about this gap. It's actually going to be 2 gaps that we're going to talk about. The first gap is a gap between what we do, and that's the royal we of healthcare, what we do and what is known in the literature, what is known as best practice. And so I want to think about this gap first. And you can see from this quote here that I think really resonates with me. Much of an experienced practitioner's daily practice has less to do with solving problems than remembering solutions. And so if you think about it, that doesn't actually equal lifelong learning. That equals remembering what you've done in the past and just doing that over and over and over. So for physicians, that means I can actually predict how they will treat diabetes, hypertension, certain cancers based on what year they graduated residency and where they did their residency training, meaning they don't continue to learn. They always practice the way they did at the end of their training. There's actually a 17-year gap between new drug in the literature and the average clinician incorporating that into her practice or his practice. Now, I looked for data around physical therapy, and clearly you all are not as appalling at this as we are, because I couldn't find any evidence of how strikingly bad you are, because you're probably not compared to us. But as physicians, we are not good at this. So think with me then, as I think about our accrediting bodies, our LCME that oversees the med schools, the program that oversees the residency training programs, our medical boards, our AMA Code of Ethics, all of them explicitly note we should be lifelong learners. Just for the sake of completeness, I did pull up the APTA guidelines, and it does say lifelong acquisition right here, and down here it specifically says lifelong learning. So if you all are held to this board and your code of ethics, you have been told you have to be lifelong learners. But I'll be honest, I don't like doing things because somebody told me I have to do it. That really doesn't seem authentic. So why is lifelong learning actually important? And I would argue that it's important for the sake of our patients. That's really why. That they need us to be at our best. They need us to know what the best therapy is, and when the therapy isn't available, to be able to figure out what is needed for them. So that first gap between what we do and what is known, routine expertise is what the literature would say is needed to do that. To take a known solution, to have the appropriate one, but a known solution, effectively and efficiently apply it to that situation. But we also need something else. And it addresses this second gap that we haven't talked about yet. There's a gap between what is known in the literature and solutions to new and novel challenges. Equally important, but not a solution that we can take from the shelf and just apply. So Maria Malopoulos and Nikki Woods framed it this way, that adaptive expertise is actually the solution to that, and that clinicians are being confronted by more and more and more new challenges, inpatient setting, outpatient setting, ICU, physical therapy, nursing, respiratory therapy, physician. We are facing challenges in providing the best care. And so they would argue that adaptive expertise is how we address that second gap. And so we'll talk a little bit about this, and it's not an either or. It really is a complementary set of expertise that is used appropriately based on what the situation would be. So you're off the hook for the next 4 slides, because again, this is physician specific, but I would argue it probably applies, but I won't make any assumptions. But these are 4 assumptions about practicing physicians. We as practicing physicians will naturally reflect on our own performance for the sake of highlighting weaknesses and gaps. This would be lovely if it were true, but it's not. We don't do it. There's really good data that we will not look for our own areas of weakness. I'm sure it's not true of you, but it is of us as practicing physicians. But let's say for the sake of argument, we do that. The second assumption is that we are actually able, if we look, to identify our own areas of weakness. Unfortunately, we're not very good at this either. There is really good evidence that we are horrible self-assessors. I won't do it, but I could ask you to raise your hand if you're an above average driver. Most of the hands usually go up. And so it's either something about being a physical therapist that makes you a great driver, or we're not great at self-assessing. We think we're the muscle man, but really we're that nerd. And that's okay, we should embrace our inner nerd, but we have to work on that as skill. But let's say for the sake of argument, we try to look for our areas of weakness. We actually find them. The third assumption is that we'll actually then try to address those areas of weakness through learning. Did we get this one right? No, as physicians, we don't get this right either, because it's hard. We want to focus on areas where it's easy and fun, and actually areas that are probably already strength. So hopefully you can resonate with this, but this is the equivalent of skipping leg day, doing something that you're already really good at, like this gentleman focusing on his upper body to the exclusion of his lower body. Lots of problems you can probably already foresee for this young man. But let's say for the sake of argument, we do all 3 of those. We can find our weaknesses. We can actually identify them. We do try to learn. Then after we've learned, the 4th assumption is that we'll actually incorporate that new knowledge into our practice. We're not good at this either, at least as practicing physicians. The evidence is really good that we are horrible. At a typical CME event, only 64% of people will plan to make any changes. And of those that say they are going to, less than half actually change their practice. So we end off a little bit worse than we started because we're a little more familiar with some of the ideas, but we didn't actually change our practice. We haven't developed routine expertise or adaptive expertise. We have just continued to do what we originally learned. And that really is a problem for our patients. So we've just talked a little bit about the why. I want to focus now in on what expertise is, because I think that's where we want to be going. Any movie fans in the group? If I could see all of your hands, hopefully they all went up. Apollo 13, great film. If I show it to my students, Many of them have not seen it, which breaks my heart a little bit. But Apollo 13, there's the pivotal scene. Houston, we have a problem. Ed Harris talks about, we've never lost an American in space. Failure is not an option. And what it boils down to is a problem they've never solved before. It is a new challenge for them. They have to make the square thing fit into the round thing. It was a matter of carbon dioxide removal and oxygen filtration, all of those things, but they had never solved that problem. So they had to, based on what they knew about physics and what was available in the capsule, address that problem in a fairly acute setting. I won't ruin the movie, spoiler alert, but it ended okay. Or a more recent version, The Martian, if there are any Matt Damon fans on the call. He's trapped on Mars, and he has to use his skills as a botanist to grow food so that he can stay alive. Again, fascinating, while he hopes that his team will come back and rescue him. All right, big screen down to the smaller screen. Any Mythbusters fans? If you haven't seen this show, these two guys, and now they have some partners, try to disprove myths that are out there on the internet. And if you have seen the show, does their first attempt ever work to disprove the myth? No, it doesn't. And so they iterate for the rest of the show based on their knowledge of explosives and physics to try to address and prove or disprove a myth. That to me is adaptive expertise. They've never had to solve problems like that, but they take what they know and apply it. And then lastly, I won't ask you to look down, but some of you might actually be wearing products from Patagonia. In his book, the CEO, Yvon Chouinard, Let My People Go Surfing, talks about how they created capilene, which is one of their base layers. They were having a problem where the base layer for climbers would freeze as they sweat onto it when they were at high altitudes. So they created a new type of filament that was hydrophobic on one side, hydrophilic on the other side, so it would pull the sweat away from you and then put it on the outside of the garment so that it wouldn't freeze on their body. Cool innovation. So solving a problem they'd never seen before based on what they knew about cloth and manufacturing and things. So if you look at the literature, this is what the literature has to say about adaptive expertise. It really is that ability to function on the everyday task. So it has the routine piece, but it's also the expertise to create solutions to those workplace challenges. And so it really is important to have that ability to recognize the routine approach won't work here. So I can't use a known solution. Reframe the problem in a way that allows exploration of new concepts, i.e. learning, and invention when appropriate of new solutions, i.e. innovation. So you need to be able to do both. So this is, according to the literature, is a learned skill set. There are habits of mind involved, and it develops over time with practice. So we actually start talking about these ideas with our students before they even matriculate. And then in week 1 of med school, we start talking about this. And then we have built out different curricula for them over the course of their 4 years with us. All right, so let's dive into the nitty-gritty a little bit of how do we actually develop this. And so Gail kindly alluded to this original paper around fostering the development of master adaptive learners that I was lucky enough to be part of with some amazing educators. And the book that came out, again, I don't get any proceeds, but I do think it's a great resource for some of these ideas. So as we think about it, the master adaptive learner is an individual who utilizes a metacognitive approach to self-regulated learning that leads to adaptive expertise development, which, okay, this looks like a bunch of words, but really 3 big ideas. It is metacognitive, and we'll talk about what that means. It is self-regulated learning. So there are actually very few new ideas in this model. We are pulling from different areas of general education, medical education, health professions education to create a shared model. It leads to that self-regulated learning and adaptive expertise. And that for us was actually one of the big benefits of this work, was creating that shared mental model, a shared language that we could use between learners and teachers to facilitate conversation, to help figure out where people were getting stuck and how we could offer more information. So here's the first shot I'm going to give you of the model, which the first time you see it is very overwhelming. And so don't be overwhelmed. We're going to walk through piece by piece the different areas of this, because I want to highlight a few things. So you'll see up in the upper left, there's actually multiple heads. And that really is to indicate that we think learning happens as a team, that it's not just a solo individual learning, but it can very much happen within teams. But staying in that upper left area, there are 4 skills that we think are going on continuously throughout this whole process. Self-monitoring being one of those, that ability to notice our own actions. How are my emotions? How am I a little revved up? Am I a little bit excited? Am I a little down today? How am I acting in this moment? How am I feeling? The metacognitive skills around setting goals, planning an approach, monitoring progress, making adjustments. The ability to reflect is critically important, whether it's before, during, or after an event, to pull out that learning, that understanding from the experience. And then the higher order cognitive skills related to critical thinking. All of those are happening throughout this type of learning. All right, you can see there's a little rheostat at the bottom called coaching. Again, you can absolutely learn without a coach. I'm not here to say that you have to have a coach, but I would argue you can learn far more effectively based on the literature with a coach. I don't know if there are any Atul Gawande fans on the call. If you haven't read his stuff, I highly recommend it. He wrote a piece in 2011 in the New Yorker where he posed the question, top athletes and singers have coaches, should you? And so he talks about his experience as he's a general surgeon that does a lot of kind of thyroid work. He was about 4 or 5 years out in practice and he felt like his skill was plateauing, wasn't getting worse, but really wasn't getting better. So he brought a senior surgeon in to observe him and to give him feedback, and gave really concrete feedback, like the way you held your elbow kept your first assistant from seeing the field. You have an economy of motion that's not hot, that's not good, which for surgeons is really important. Clearly, I'm not a surgeon. You can see my economy of motion is all over the place. But he said that his skills never improved as much as working with that coach, so he continues to use a coach to provide that outside perspective for him. It's driven by these 4 batteries, the whole process. And each of these could be their own hour talk, but curiosity, that just desire to know more. Again, think about the students you have enjoyed the most working with. Has been so much fun. It's because they're curious. They want to learn. They want to know more. Internally motivated versus externally motivated. Mindset here connects with Carol Dweck's work around growth mindset. So running towards challenges, trying to highlight what you don't know as opposed to hiding it. And then lastly, resilience or grit, as Angela Duckworth talks about. Again, so much buried within the literature for each of these 4, but we don't have time today to really dive into that. I do want to also highlight that all of this happens in the environment of a hospital, an outpatient setting, a clinic, and that's a very different place than a classroom. Both are good, both are important, but I can control everything down to the temperature and the lights in the classroom. The clinical setting is very different. For the record, it's always too cold in our classrooms, according to our students. But as you think about the clinical environment especially, things are rapidly changing. There's not enough time. There's intra-team dynamics. I'm sure this doesn't happen in your world, but in my world, my students will go out and see the surgeons making fun of the internists and the internists making fun of the emergency medicine physicians. And that is not something I would ever put in a learning environment for my trainees to see, because that's not productive or helpful. Complexity, conflicting priorities, space constraints, policies and procedures. We've alluded to that already just a little bit. So there's a lot that goes into that environment that might facilitate, but also might impede this type of learning. All right, but now we're honing down into the middle of what are the 4 gears? What are the phases of this actual learning and how do we do it? And so planning, learning, assessing, adjusting. And for those of you that do any quality improvement work, this should look really familiar. This is functionally a PDSA cycle, or plan, do, study, act, from the quality improvement world. And we love the idea of trainees, whether they be students, residents, faculty, medical people, nursing, respiratory therapists, physical therapists, all of us, we are all learners, regardless of the stage we're at. And we all should be doing quality improvement cycles of ourselves as learners. And so here are the 4 phases, and we'll walk through each of these because I really want you to get a sense of what they're about and how you might do it. The first is the planning phase. And there are 3 components to this. The first is identifying a gap between what is and what should be or could be. Then selecting an opportunity for learning and searching for resources for learning. So let's talk a little bit about this planning phase. If you haven't seen this book, I highly recommend it. It's written by Catherine Schultz. She's also got a fabulous TED Talk if you want the abbreviated version. But she poses the question, or poses the idea, that most of us hate being wrong. We run away from it. But instead of that, we should run towards where we're wrong, because that's where the learning happens. And I used to have a faculty member when I was a resident who would say, I'm going to keep asking questions till you get one wrong, because that's where the learning happens. And I love that. It stuck with me, because being wrong is not a bad thing. It's just an opportunity for learning. And so she really does a great job of framing that in her book. And so that ability to identify a gap is really an entry point into learning. It can be around knowledge, it can be around skills, it can be around attitudes, but this really does impact the provider's ability to provide expert care. Now, you guys are thinking and talking, at least according to what I've heard, around competency-based assessment. I think this is a perfect place to use that assessment data to guide learning. And it can be course assessments, quizzes, exams, peer feedback, national board exams. There's a lot of different data streams, but using that data to highlight gaps is a great way to help our learners enter the cycle, or for ourselves, using patient safety, quality improvement data about our own patients to help improve our abilities. All right, so after we've done the planning phase, which I would argue most of our students and most of us as practicing clinicians probably skip. And we're like, if we've got a little bit of time, let's just dive right into the learning. But hopefully we do that. Once we've done that, we can dive into the learning and actually engage in it. And I would argue we also don't do a great job here. We use a lot of bad strategies. Maybe you don't, but again, I'll speak for myself. Rereading. It is a horrible strategy according to the general education literature on multiple fronts. It's time consuming. It doesn't lead to durable memory, and it gives you that false sense of familiarity. So you think you know more than you actually do. Horrible on all fronts. And we'll add with it highlighting and underlining, which I'm a huge, I have a huge issue with, because I actually really like to highlight and underline. I got to read. It keeps me more active. I have all kinds of rationalization, but it's not effective as a long-term strategy. And cramming, which our students could probably teach us a few things about. But this idea that learning is deeper and more durable when it's effortful is really hard to hear, right? If it's not hard, you're probably not actually learning. And that is just important to remember. And that Brown wrote a great book called Make It Stick that takes a lot of the educational theories and makes them really easily accessible for those of us that want to read it in that form. We talk about with our students a lot of different strategies, but these are three: knowledge retrieval, so self-testing, self-quizzing; spaced repetitious learning; concept mapping is one that I'm a huge fan of. But then I also think about us on the educator side. What are the teaching strategies we use? Are we still wedded to lectures, or have we started to use more problem-based learning? Are we using strategies that have good educational science also? So it's not just the learner, but it's also the teacher. So the fingers are pointing at us also. But this is what we hear. It just takes too long to learn that way. Just let me reread it. That's true. I think the evidence would support that it does take longer, but our hope is that with that initial investment of learning how to learn, of spending that extra time struggling, that the actual outcome in the end will be better, that the learning begets learning and will ultimately be far more impactful than the slow incremental slog, if you will. Okay, so after we've done the learning, we have to decide if that was the right things to learn. So the assessing phase becomes incredibly important. And so this trying out what was learned is the mixture of informed self-assessment with external feedback. Now, I would argue this is another place where using the competency-based assessment data is incredibly impactful. Having, whether it's a portfolio or a dashboard or some way for the learner, again, whatever stage we're at, we're all learners, to look at our own performance, as well as thinking about our ability to self-assess and seek out feedback. So this is an example of our portfolio for our medical students. This is around one subcompetency related to medical knowledge. The details aren't important, but you can see this is a student on day one of med school. They're on the kind of entry level 1 to 5, 5 being aspirational, kind of 6-month intern scale. They started around a level 2, which is great. We've done the math. The trend is upward and rightward, which is great, thinking about development. But we also have milestones around their practice-based learning. So their ability to learn in practice, to receive feedback, to incorporate it. And being able to have conversations that are data-driven is a great way to help them assess whether or not they've learned the correct things, whether or not they're improving as we wanted. All right, so after you've done that, then we often skip this last step also of actually incorporating what we've learned into our practice. And I would argue this is one of those places where we can actually learn a lot from the business world. At the core, incorporating our new learning into practice is a change management problem. And actually, there's good literature around the bigger the problem, the less likely we are to do it. So if I have to change which antibiotic I use, that's not a big change, right? I can remember to use ampicillin versus amoxicillin versus penicillin. Okay, that's a change, but it's not a big change. If I was a surgeon in the 90s and used to always take gallbladders out with a giant open incision and this newfangled laparoscopic surgery came along, this technology, that's a bigger change because that starts to impact my identity as a surgeon. I have to learn a lot of new skills and my whole team has to learn new skills and new equipment, et cetera. Or as I was thinking about how this might apply to the physical therapy realm, if you work with individuals post-joint replacement, for example, if the surgeon changes the way she does joint replacements and it creates a whole trickle-down effect of new problems, you continuing to do therapy the way you've always done for the old way doesn't actually solve the new problems. And so being able to adapt and think about, okay, hopefully the surgeon has talked with you about their new way to do this to help think with you about how might we rehab and do great therapy for her patients. But if she doesn't, unfortunately, you're gonna have to figure that out and solve that challenge anew. So again, thinking about, are you the only one that will be impacted? What emotions are involved? The bigger the change, the harder it's gonna be. But there's a lot of great literature around change management strategies that we can pull from the business literature. And again, I would encourage things like Cutter's model of change, or there's a great book called Make It Stick that the Heath brothers wrote that really walks through a great model of change management. All right, so in the last few minutes, I want to change gears, but think with you, not as educators thinking about your learners or even practitioners thinking about yourself and how to improve. But in the last few minutes, I want us to think about ourselves as educational leaders and how these principles might apply to the leadership realm. And I have become more and more convinced over my time and in my career thus far of how integrally related learning is to leadership. I love this quote by JFK that leadership and learning are indispensable to each other. Or the ever prolific Anonymous, the ability to learn is the most important quality a leader can have. I really think this is accurate and true and a challenge to all of us. So in the business literature, they talk about the leadership context that probably is applicable to all of us as a VUCA world, or volatile, uncertain, complex, and ambiguous. Now, again, as you think about the clinical realm, I think that is absolutely true every day, all day. I think it's also true of us in the health professions education realm also. As we think about, even over the last year and a half, all of the changes that have happened with the way we educate our students, a lot of volatility, a tremendous amount of uncertainty. Oh my goodness, the complexity in thinking about it, and a lot of ambiguity that we as leaders have to hold on to. So they go on to talk about getting rid of that VUCA type world and thinking about providing vision, creating shared understanding, providing clarity as a leader, and being agile. That's a very different approach than being fragile, as they say in this graphic, which I think is a little cheeky, but kind of fun. So how do we actually do that? So there's a couple of books that I share with you because I think as I have read them, they highlight for me how important the leader-learner relationship is. So Doris Kearns Goodwin talks about presidents, and it walks through, it was either 4 or 5 different presidents, and walks through their upbringing and how they led during turbulent times. They were each faced with unknown, previously experienced challenges and had to solve them in the moment. The leadership moment talks about 9 different stories. There's some mountain climbing, there's the problem of river blindness, a lot of different types of issues that all required the leaders to solve new novel problems. And I would argue they're using adaptive expertise. They're learning new things. They're innovating in a way to solve problems. And they had to have that foundation to do that well. Canoeing the Mountains walks through Meriwether Lewis and Clark's expedition and how they got to Limhi Pass expecting to see the West Coast, and there was a mountain range. And so they came with canoes and had to leave the canoes and trek through the mountains, and all kinds of leadership lessons that came out through that. And then in You're It, they walk through some of the approaches of FEMA, an emergency response around the country to solutions that have never been, to problems that have never been faced before, having to create new solutions. They talk about Deepwater Horizon down in the Gulf and a lot of other different natural disasters that led to problem solving that had to be done well. And again, there's one of the themes, and most of them don't talk about, although Canoeing the Mountains does, don't talk about adaptive expertise. That's absolutely what they're describing. Okay, so as I think about this, if you are leading, whether that's leading in implementing problem-based learning or adapting your problem-based learning, or flipping learning fairly urgently to distance learning or Zoom-based learning, or really trying to implement truly impactful diversity, equity, and inclusion initiatives, and not just checking the box that you've done something, but really trying to move the needle. Whether or not you're just innovating within your institute and trying to think more globally. Or if you're thinking about leading within progression, thinking about competency-based and time variable. I would argue that all of those leadership efforts are going to require both you leading, but also learning. And it's the learning that will set up the leading to be effective and productive, and ultimately accomplish what you hope it will accomplish. And so I recognize that was probably a whirlwind, but just to recap a little bit of where we've been. We started off with why lifelong learning is needed. We talked about 2 gaps, the gap between what we do, the royal we of healthcare, and what is known, and the second gap between what is known and solutions to new and novel challenges. We then talked a little bit about different types of expertise, but really it's all expertise depending on what situation you use one or the other. That routine expertise that is the efficient application of known solutions, and adaptive expertise, which really is incorporating new learning and innovation to solve those novel challenges. And then we talked a little bit in the middle there about the Master Adaptive Learner framework and thinking about the learner characteristics, curiosity, motivation, mindset, resilience, the impact of coaching, thinking about the environment and how it can really impede or facilitate this type of learning, depending on what's in that environment. And then the nitty-gritty of how do we actually help our trainees and help ourselves learn. And we can go through some examples if you like, but really thinking about if the learner is struggling, it's actually quite helpful to look at and work through with them. Is it a planning problem? Because if you're offering up educational strategies to a planning problem, that's not actually meeting them where they are and what they need. But if they have a learning strategy problem, great, let's offer the help there. And so that ability as an educator to work with the trainee and help them identify where their struggle is, and then offer appropriate coaching and guidance around that. And then lastly, just thinking about ourselves as leaders and curriculum developers, as innovators. How do we do our best to combine the learning and the leading? And so in the last minute or so that I have, I want to leave you with two pictures that are actually on the wall in my office. The one on the left is remember why you started. And my guess is I can predict that your why is probably similar to mine, that it's a combination of a desire to provide great patient care to those patients that we work with. And it's probably also involves a passion around students or trainees or learners of some form or fashion. So the twofold why of great patient care and great education. And then the other is always be learning it. So that really is my challenge to myself as well as my challenge to you. And so I want to pause there, and I welcome questions. If we don't get to all of your questions, feel free to email me. My email is here. So much fun, and I actually look forward to hopefully being able to engage and interact with you all a little bit around these ideas. So let me stop sharing so I can see more of your faces. And then Greg, Gail, how do you handle question and answer? The floor is yours.
Right. Thank you very much, Dr. Cutrer, for a very engaging and igniting keynote. So now we will open up the floor for questions. We've got half an hour with Dr. Cutrer, so let's pick his brain. We've got an expert among us. Many experts are here in the room, but let's all pick his brain and ask him some questions. So to do that, just use the raised hand feature down at the bottom. You will see the reaction button if you scroll down there, and most of us are familiar with Zoom by now, but there should be a raised hand function which you can use to raise your hands, and we will call on you as the questions come in. And I will give the floor to Rain Osborne.
Dr. Cutrer, appreciate you coming and speaking with us tonight. I really enjoyed your work, and a lot of my own research is based around much of the work that you're doing and the master adaptive learning model. So you're really interested in that. So I could probably take up the half hour asking questions myself, but I'll start with one and then I'll try to remain silent there. So I'm going to pick on the environment, the learning environment piece. And so in particular, that's where I have some interest in looking at that more like a workplace learning environment. So not so much of a school, academic type environment. And you talked about the learning taking a longer time, being the active learning and really the process of the master adaptive learning taking a lot of time and effort. But that's often in strain with just the challenges, especially in rehab, of the financial challenges of an organization and putting those two pieces together, having a strong learning environment to support this model, while at the same time, meeting operational costs. I'm just, curious what sorts of things, you've run across in that area and how that's been solved maybe in other areas.
Oh, such a great question. Thank you. It's wonderful to hear of your interest in the work, but thank you for that question. I think there's a couple of ways you can tackle it. At the core though, the institution, the healthcare system has to value education, because if not, the competing priorities will always come to play. And so one of the practical ways, I think, or a couple of the practical ways that plays out. One, if the system values education, it will make sure that it allows learners access to the different areas within the environment. And so again, I work at Vanderbilt, so thinking about our healthcare system, one of the nice things we have on campus is we have our adult hospital, our children's hospital, our rehab hospital, our outpatient clinics that include the physical therapy where I go, our psych hospital, our VA hospital are all physically connected. And there's been a commitment from our leadership that we will have learners in those spaces. And so just really kind of we're going to plant a flag that yes, this is important. And I think that's helpful, but at the same time, there's still requirements around productivity and throughput, the number of patients and all of that. So one of the ways we've tried to tackle it for our students actually has been also a commitment from the institution, but a very different kind of institution. So, or a very different kind of commitment. We have the school now funds a small cohort of what we call master clinical teachers. So it's a group of our best clinicians, best educators on campus. And what we've done is protected part of their time with FTE support to spend directly teaching our students. So they do direct observation with our students in the real setting with real patients. They observe them, they give them feedback, then they document that in our assessment system. And so that encounter takes about an hour with each student. So it's a huge commitment of time, but that faculty master clinical teacher has part of their FTE provided to do that. So they are not responsible that afternoon for patient care. They are purely there to teaching. That's not even a phrase. They're purely there to teach. There we go. And so one of the things we have found is that by protecting the time of some of our faculty, they're not having the competing priorities. They're able to just focus on the teaching, and they can be more productive from a teaching standpoint that afternoon instead of having to run back and forth and see clinics. Now, that said, obviously we can't do that with all of the faculty, and full disclosure, I would love to see us continue to grow and expand that, because our students consistently say, and regardless of what survey it is or feedback session we have or curriculum committee meeting, that those master clinical teacher sessions that they have about 12 or 14 of over their clerkship year are the most impactful experience they have at our school, because it's focused teaching time, targeted feedback with an amazing educator. And we do a lot of faculty development with that cohort of teachers. And so we are paying them. And so we expect them to come when we do faculty development. But the flip side is we're doing a lot of faculty development with them. And so they actually feel that they're able to make a bigger difference. And so that's one of the strategies we have tried to do. You have to have the high level commitment, but then the practical boots on the ground, actually carving out some time for people to do that was one of the ways we have found to try to address that environment. That was a great question. We'll see a couple of other hands.
Yeah,
Greg,
thank
I'll
you,
let you
Brian,
call.
for the question. So next up is John Buford, and then Mary Blackington, and then Chris Sobleski.
Hi, Dr. Cutrer. John Buford. I'm the program director at Ohio State. And one of our famous football coaches, Woody Hayes, said, "You win with people." You talked about curiosity and some other learner characteristics. We went to a holistic review several years ago, and curiosity was one of the things that we decided was a value that we wanted to assess and to try and select for in our incoming class. And I just wonder how, if you don't have the right people who come in with at least some inkling of those characteristics that you want, it's awfully hard to train that in. Certainly you can teach skills and so on, but they have to come in with certain attitudes. I think it's hard to change those. So what would you say about, selecting the people who are ready to become adaptive learners into your class in the first place? How do you do that?
Ooh, that's a fun question. I wish I had the answer. I'll tell you a few thoughts. And just for the record, I didn't catch the Ohio State University in there. I thought you were like contractually obligated to include the. So I think it's a really important question. Now, I would never want to use some tool or a screening that said, if you're not a master adaptive learner, you can't come to school, because I inherently think that these things can be developed. But I totally agree that if a student shows up curious with a growth mindset, internally motivated, they're far more likely to succeed than someone who's not. And so we also have taken a holistic review approach, and we do a blinded, one of our interviews is open resume, look at all the details and the numbers, but one of them is totally blinded to that. And they actually just ask questions around, tell me a time when you had an ethical challenge. But one of the questions we ask is around curiosity. Tell me a time when you were, and it's one of the ones I love to ask when I've done this in the past, is tell me about a time where you got curious about something and how you investigated it. And if they have to struggle to come up with an example, that to me is a little bit of a red flag. If they can come up with 10 examples of, I saw this YouTube video and then I watched 10 other videos, because, and I don't care if it's YouTube. I just really care that they got interested in something, they didn't know something, and they followed that. The rabbit trail is actually a good thing here, where they get lost of, seeking out the answers. And so for me, again, past behavior is one of the best predictors of future behavior. If they're able to talk openly and freely about experiences where they have demonstrated curiosity or a growth mindset or resilience, those to me are probably a good indicator that they probably have that. Now, I will say, and it has been said, there we go. The educational system, especially high school and even some undergrad, I fear beat the curiosity out of some of our students, right? We train them, do not be curious. it's going to waste your time. Just focus on what I tell you to learn. And so that really is a flipping of the script when they get to my med school, at least, and I would imagine it's probably true of a lot of your institutions. And I tell them, Curriculum 2.0 is not a static list of just learn this, learn this, learn this. I can't teach you everything you need to know in 4 years. So we're going to learn how to learn. We're going to focus on that. And even though you've proven you can do great on tests, that doesn't actually equate to being a great physician or a great lifelong learner. And so some of it is, I do worry, going back to the learning environment, that the environment actually impedes some of those things. And so I hope if we have created an environment that fosters curiosity and fosters resilience and some of those things, that even if they don't show up demonstrating all of that, we'll be able to pull it out or help them develop it.
Thank you. Next up is Mary.
Hi, Dr. Cutrer. My name is Mary Blackington. I'm the director of a collaborative partnership program at Rehab Essentials. Thank you so much. I feel very energized and eager to apply what you've been talking about. I do have a question because I'm really intrigued with the idea of having that master clinical teacher more frequent and earlier in physical therapist education. And I wondered how important it was for that person or that idea of that assessment to be truly authentic in a full-blown clinic, or do you feel it could also be done with, let's say, simulation or other types of experiences?
That's fun. Yeah, I don't think it has to be either or. And so full disclosure, just one quick statement about our curriculum. So a traditional med school curriculum is 2 years in the classroom. They take the step one test, they forget everything, and then go to the hospital for 2 years. So at Vanderbilt, we redid that and started our new curriculum, Curriculum 2.0. So we have a 1-year pre-clerkship phase, and then our core clerkships are in year 2, and we have a 2-year post-clerkship phase. So actually in year 1, we have them working with standardized patients, and not our official master clinical teachers, but some of our physical diagnosis faculty that also do faculty development. So with standardized patients, and even a little bit in clinic, but more standardized patients in that year 1. It gets them used to the flow and getting feedback on some of those things. And then when they hit their core clinical experiences, when we bring in the master clinical teachers. So I would really view it as a both and, not an either or, because I think there are a lot of great things. And one of the examples that for us is thinking about things that require a little bit more skill or confidence, comfort to do. The genitourinary exam, for example, a vaginal exam, a rectal exam, a scrotal exam. Those are really awkward for our students to do for the first time, for all of us to do for the first time. And doing that with a standardized patient who's been trained to do it and who can actually give them feedback is really helpful. So I wouldn't want them to just run out and try that with a real, quote, real patient to start off with. So actually doing it on a task trainer first, to a plastic model, and then working their way up to a standardized patient, and then working their way up to a real patient. That to me makes far more educational sense than just either or. But again, those are all fairly resource intensive. And so trying to think about across the spectrum, how do we provide those developmental steps to allow them to really grow?
Thank you.
Yeah.
Chris Sabelsky.
Thank you, Dr. Hartley. Thank you so much for your information thus far. I've really enjoyed the conversation. It's very stimulating. I'm very interested in competency-based education and the way it develops towards expertise. One of your last slides actually pictured the development of expertise, the how, and it almost put it in a linear fashion. And that has been not my experience. Linear growth, the growth towards expertise is linear in nature. And I was curious if you'd be willing to discuss your challenges with the continuum of development, because it tends to be both vertical and horizontal and a little bit of lateral and maybe some diagonal. And if you could discuss that with regards to the development of competencies or KSAs of leadership.
Easy answer is yes. Challenging for sure. And I don't have the easy answer. Wow, it is, you're absolutely right. And I definitely don't want to imply that it is linear. I think it's anything but. Both my own journey and as I think about my students and their development in a lot of the different competencies, but especially leadership. I think there are things that can make it more steady as opposed to the fits and starts that it often happens for many of us. Ooh, yeah, that's the wrong way, and coming back. And so I think a little bit about, kind of weaving in and out, and the closer you can stay to the main road, the better as far as progressing, but it's definitely not linear. And so the things that I think are helpful to do that are things like reflection. So that idea of the unexamined life. I would say the unexamined experience is probably not impactful for developing as a leader. I've been through a lot of experiences as a junior leader, as a now mid-career leader, and I'll be honest, there are probably some that I should have learned lessons from that I didn't. And it was because I didn't force myself to reflect. I didn't take the time to really say, what was the struggle there? Not just that, what did I do or how did I mess up, but what was the real core issue there and how could I learn from it? And so building in the time for reflection is one of those things that I think can actually make some of the fits and starts a little bit less sideways diagonal in that. So I think that's a great one. I think that outside perspective, whether it's a formal coach or really just a partner in crime that will give you some feedback. I have found in my own leadership development, one of the things that I am horrible at is my default answer is yes. When people ask me, hey, will you do? My answer is yeah. I'm like, yes, I'd love that. That's a great opportunity. Yes. Enough that one of my colleagues gave me a no button, like the easy button. It says no 12 different ways. And so actually what I did and that was really impactful for me as a developing leader was to have one of my slightly more senior colleagues meet with me. And he said, anytime you get asked to do something new, say, give me 24 hours to think about it, and then we'll have a conversation. He said, I'm going to ask you the hard questions. What are you going to have to give up to do this? Are you actually going to be able to do it? Do you have the bandwidth? He said, I will not tell you what to do, but I will force you to ask and answer the questions, or at least think about the questions. And so for me as a leader, that was, again, a specific skill that was great to have that person in my development, in my life, to really be able to force the hard questions. And so that's a long-winded answer to say those were a couple of the strategies that I have found helpful for making it a little bit more smooth, but it's very much still not linear. Totally agree. And then we could have, again, we could give whole talks or have whole hours of conversations around some of the other competencies within medical school. Again, my guess is there are a lot of overlap between patient care and medical knowledge and some of those competencies, and the development in each of those is also not linear, and how data can inform that, how coaching can inform that, et cetera.
Thank you so much for your answer. Thank you for validating us. Thank you.
Thanks for the question, Chris. And Mahia Downs, your turn.
So thank you very much for this thought-provoking presentation. I'm a faculty at College of St. Mary. So I love how you talked about the value of being wrong. And I wonder what strategies you can suggest to make our students more comfortable with being wrong, more comfortable with raising their hand and having the wrong answer, because that is where the learning occurs.
So this is really hard to do because we hate being wrong. And we hate it when other people know we're wrong. And so I'll be honest, there's a couple of things. Some are structural and some are a little more behavioral. When we moved our new curriculum, we moved the clerkships to year 2, we took it from a graded clerkship year to a pass failure. And that change alone made it far simpler for our students to say, I didn't feel that liver, I didn't hear that murmur, I have no idea what's going on. Because they were no longer performing or competing for a grade, they were trying to learn. We set the bar high, we wanted them to learn the content, but they're no longer competing with each other, they're no longer trying. And so that was a structural change that we made that we think, and that they've told us, made it easier for them to acknowledge what they don't know. And so I think there are some structural changes like that. But nitty gritty, day by day, the strategy I think is actually the most impactful is role modeling. And so I'll be honest, it took me probably a couple of years as a junior faculty to get comfortable sharing my own stories of failure. And now, once I did get comfortable, I quickly saw how much more willing they were to share their stories of error, how empowering it was for them to hear me say, man, I totally blew it here, and here's what I learned from that. And so I do that in small group learning. I do that from the podium when I'm lecturing with my students. I do that in the ICU when I say, you know what, this was a near miss. And let me tell you why, I remember to ask that question because I made a mistake as a trainee and here's what happened. And so I'll be honest, I think that role modeling is probably the most impactful way, kind of boots on the ground, day to day, to make that happen.
Thank you. Yeah, that's really helpful.
Next up, we have Christopher Meacham.
Thank you, Dr. Hartley. My name is Christopher Meacham. I'm the training director at the Jesse Brown VA Medical Center in Chicago. And Dr. Cutrer, I really appreciate the conversation and discussion, so thank you. During your talk, you were talking about you mentioned the 4 different phases: planning, learning, assessing, and adjusting phase. And specific to the adjusting phase or the change management phase, would you be willing to expand on that particular phase and share a little bit what that looked like in your organization or even in the profession?
Yeah. Ooh. So I think this is one of those where it depends which change lens we're thinking of. Change is all around. And so I try to think about it, change internally. How do I change my own views, my own beliefs? How do I incorporate that into my thinking? And, you know, that can be everything as far as, you know, becoming aware of an implicit bias that I have. We have a lot of conversation going on around that. And so part of the first step is actually being aware that I have a bias. And so being able to name that, acknowledge that, and then think about how to change it. There are changes with our patients directly, and thinking about patients with obesity, patients with smoking or other behaviors that are detrimental to their health. How can I, as their provider, help them engage in change management? And then I also think about change management at the system level, thinking about educationally. And have learned a lot of lessons the hard way of trying to implement change for the sake of the students, but totally missing the mark and implementing something that didn't address the real issue, that didn't actually help them. And so this is one where I actually really like the model from Chip and Dan Heath in the book Switch. That is, I might have used the wrong title. Yeah, I think it's Make It Stick. No, it's Switch. Sorry, it's Switch. And so they have a 3-part model. So their picture is a rider sitting on top of an elephant walking down a path. And the model goes that the rider is the intellectual component. And so any change management issue has to involve the intellectual component. You didn't know something and that they're providing information, but it's actually fairly small compared to the others. The elephant is the emotions, that you have to engage emotion and figure out where the barriers are related to emotions. If we want to implement a change in the clinic and my nurse feels like he is going to be negatively impacted because he's going to have to stay late, I need to be able to address that emotion. So the emotion is the elephant. And then the path is, what are the systems barriers that get in the way and how can we eliminate those? And so their frame is that whenever we think about a change problem, we need to have the intellectual piece, yes, but it's actually pretty small compared to the emotional piece and clearing the pathway. And so we teach that to our students as they think about working on change management with individual patients. We think about it as we roll out different curricular issues. And so it's one of the frames I've found helpful.
Thank you.
Yeah, absolutely.
Next is Mark Bishop.
Thanks, mate. Dr. Cutrer, thank you. Mark Bishop from Florida. So one of the questions, this is truly egocentric, so apologies, everybody. This is going to be all about me. But listening to your talk about the faculty having time to teach, one of the challenges that certainly our institution has is we don't have a health system. And so when our students go to the clinic, where I'm, as director, hoping that that type of experience can be had by all students. And it's going to be variable. And I'm wondering, so it sounds like you guys are all incorporated, part of the same system, but if you've had any experience kind of advising groups that don't have a health system about how those type of kind of mentoring and learning experiences can be best fostered at a separate location.
Yeah, it is a challenge, and we do have some of that. And so for us, the biggest equivalent would be, we want our students in a primary care clinic out in the community. And many of those preceptors are not Vanderbilt. They're not part of our system. They're just out in the community. And we think it's a really important experience for our students, but yes, we don't have direct control over their funding or any of that. And so we've tried a few things, some of which have worked, some of which haven't. We have tried kind of stipends, everything in the $500 to $1,000, occasionally $2,000 range. For a busy clinician, it might or might not be an incentive. For most, it's probably not. They'll do it and they'll take that if we're giving it, but that's not really why they're doing it. The university has offered electronic access to the library for some of them in kind of an adjunct position. Whether that is impactful or not, I don't know. The thing that I think has probably been the most effective for that kind of outside group that we don't have control over is offering faculty development. And sometimes we can offer it as continuing medical education or CME credits. That's fine, I'll check that box for them, but really framing it more as we want to invest in you as a teacher, as a clinician, and that investment they see as providing value. And so part of it then goes back to one of the things we do know about our faculty that work with trainees, especially the students, but trainees across the board, is they in general have more job satisfaction and they find more meaning and value in what they do because they're educating. And so being able to somehow connect the ask of, can you take one of our learners, with that of, we would love to invest in you. And we have seen that those that have done this in the past have found meaning and value and worth in the opportunity. Again, it's still an ask of them that they're probably spending time before or after their normal work. And it's a hard ask, but those have been some of the strategies we've tried, with that last of which being the most impactful.
Great, thank you.
Yeah. Carol Davis.
Thank you, Dr. Cutrer. That was an excellent presentation. I'm fascinated by, we've been talking around it a little bit about what goes into faculty development. And with adaptive learning, very much what happens often is that the student and the learner, or the student and the teacher in the clinic, are presented with a catastrophic kind of moment, especially, in intensive care. And we do have physical therapists very much in intensive care and in emergency departments. But even walking a patient in the hallway can bring a catastrophic moment when they pass out on you or whatever. And in that moment, what we found very often as faculty with students is there is a regression on the part of the student, and perhaps on the part of the faculty member, of, oh my God, what am I going to do now? And the student often reacts with, just give me the you-know-what answer. I don't want to have to figure this out. Not now. We're not figuring it out now. We got to do something right now. And then how do we help, and I'm sure you're going to say faculty development, what kinds of things can you tell us about helping faculty to deal with intense negative emotional response, and how can faculty stay present in the moment and not freak out themselves, and be able to support the student and the patient or whatever in the process and turn it into a positive learning experience?
That is a challenge. I wish I could say it always works, or it could always work. I think where my mind would go is really around the role modeling again. Part of it is, we always joke about the first rule of going to a code is to take your own pulse first. That idea of, if I run to a code and my heart rate is so fast that I'm about to pass out, I'm going to be of no help to the patient. And so I need to catch my breath. And so whether it's through formal faculty development or just kind of those conversations, really encouraging the leader, the teacher in the moment, to be able to catch their breath, to check themselves, to get a quick lay of the land. But I think this is one where the role modeling becomes the most impactful strategy again. And it doesn't necessarily have to be actually to change much. But one of the things the literature would support, and I've definitely heard a lot from our students, is the students appreciate an expert, for example, thinking aloud. So if it is a critical situation, if the teacher said, is to themselves, I need to just manage this, I don't have time to teach. If they're able to just talk out loud why they're doing it, okay, I need to first establish the airway, or I need to make sure that this patient with a fall risk doesn't fall down these stairs, or whatever the situation dictates. Thinking out loud is a great way to keep the learner engaged without having to really direct all of your attention to them. And so you're already thinking as the provider there, but just verbalizing that is a great skill. Now, I think the 201 level of that is the posing a question to the learner of, what are you worried about here? What would you think if, or saying something along the lines of, I often find I'm amped up when this type of situation happens, and so I have to force myself to catch my breath. Have you ever experienced, something like that? But I think for me, the baseline 101 level would be just talk out loud, because it really allows the learner to stay engaged and really have one of the things the learners love is the kind of pulling the curtains back to how the experts think. And so I think even in a critical situation, that verbal processing, it's one of the things we teach our fellows to do when they're overwhelmed and leading a code. Talk out loud, walk through your thought process, because it will help you process, but it will also help everybody else stay engaged with what you're trying to get accomplished.
Thank you, Dr. Cutrer. We've got 3 people in the queue, so that'll probably be all the time we will have for questions and answers, but we'll try to get to you 3. So next up is Rusty Smith.
Well, good evening, Dr. Cutrer. Thank you for your time. Appreciate your passion, and it's very contagious. So thank you for that. I'm privileged to serve as the dean at the College of Health Sciences at the University of Lynchburg. And one of the things we value is interprofessional education. So I'm going to come to you from that angle. And I want to go back and I want to intersect the discussion we had about adaptive learning being more of an organic process than a linear process, which I totally agree with. Can you intersect that with using portfolios? And then also with my concern, my valuing of interprofessional education, just kind of speak to that, maybe some basic nuts and bolts. If you could point in the direction of some of your, what you consider some best practices. Very, very practical question for you.
Yeah, I love it. And we have been trying to improve our interprofessional education efforts. And I think there are pieces of it where we do it really well and pieces where I would love to see us be farther ahead than we are. I think part of it is true to interprofessional education, is true to competency-based education, starting up front with what do we want to accomplish? What's the end goal? And working backwards from there. There's great curricular design around that, understanding by design and some of those things, but really, what do we want to accomplish and how do we work backwards to get there? And so I think I would use the portfolio as a tool. So what are the things that we would include in a portfolio that might highlight really good interprofessional work or highlight really poor interprofessional work, for example? And so if that is important, which I would argue that it absolutely is, we absolutely need to have a data stream from those in the other professions around. So for me, I need to have nurse input, therapist input, social work input around my students and how they interact with the team. It's fine for me to have a competency around interprofessional communication, but if only other physicians are assessing that, that doesn't actually, it's not interprofessional. And so I think, again, if you start with the end in mind that I want we want our students to work interprofessionally, great, what does that look like? And then we have to pull in the multiple data streams to really highlight that. So building the portfolio as a tool to help us know if there's progress towards that goal that we've set at the end.
Thank you. Next is Dr. Jensen, and then we'll end with Dr. Drevin.
Okay, great talk, Dr. Cutrer. Bill, we talked about this on the phone with Greg and I did. I'm channeling Dr. Geneva Johnson here, who is always, she wrote about the DPT program before we even thought about it. So could you tell us a little bit or give us one or two kind of pieces of advice? I'm really fascinated with the innovation work that's gone around the master adaptive learner. And I think we're at a moment in time in PT to move some things forward, but we have a history of wanting all to be the same. We got to take a vote. It's got to be total consensus. And so we're our own worst enemy. So how do we help the profession really move in an innovative way? What advice would you give us?
A couple of things. One, I think having a mixture within the group that's talking, and this was my experience with the Master Adaptive Learner work, of junior people, mid-career people, senior people, so that the experiences and the perspectives are different, but to really have a discussion as equals. So I was the most junior person both on that paper and in the work, and yet because of my interest and passion, they allowed me to lead the work. And so that was really to their credit, to empower me as a really junior person to dive in and help with that. So I think that's part of it. I think, honestly, there's a sense of humility that we need to bring to the table, that while we each have our own perspectives and we each have our own thoughts about how things should move forward, to have the humility to truly listen to each other and to be willing to reevaluate or rethink. Adam Grant just wrote a great book called Think Again, if there are any Adam Grant fans, and it really challenges us to be willing to rethink our stances. If there's new data, if there's other perspectives, and so I think the humility to do that would be one that I think is really important. And then really just that desire to do better, to always be improving. And I think one of the things we have learned from a curriculum standpoint is we were never going to get it right on the first pass. Our first implementation was never going to be perfect. And so to do our best to get to 80% great, and then to be willing to quickly take the feedback and move it the next step. And so we have, even every other week, we meet with our students in what we call rapid cycle feedback to get the really kind of boots on the ground, timely feedback around little bitty things, not just necessarily the higher curriculum. So thinking about curriculum implementation, that for us was incredibly impactful to know there are certain pieces we got right, but to go in knowing we're not going to be perfect. And so we needed to be able to gather more information and change on the fly as appropriate. And so, yeah, So probably those things, the humility, that sense of always wanting to improve, that sense of a lot of diverse perspectives would be probably the three that come to mind the most. It's a fun question though. I could probably think about that for hours.
All right, Elsa Dreven.
Hello, Dr. Cutrer. Thank you so much for a thought-provoking presentation. I'm Elsa Dreven. I'm the DCE at the University of Miami. And what I'm finding in my role is that I'm having a lot of students experiencing very high levels of anxiety that, of course, have been exacerbated by the pandemic. So following up a little bit on what Dr. Davis was talking about, I can guide my students towards the right resources, but I am not a mental health care expert by any means. Finding myself limited in my toolbox of what I can do, what I can help, what I can guide them with. But even with them being one component, the other component being the CI, and what kind of tools can I help the CIs with that maybe you have some insight or tidbits or ideas?
Yeah, I think it's such a challenge right now for all of us, but especially for our learners who are trying to balance a pandemic and just the stresses of being a student, and all of the context is hard right now. You know, we think about it in a couple of ways, and we're not perfect, just to be honest. So I'll put that out there. We have plenty of room for improvement. One of the things we have tried to do is make sure that our students are abundantly aware of all of the other resources that are available, the mental health professionals, the expertise. We've gone out of our way to create more office hours, and office hours that better align with the evening times where our students are free as opposed to the day times, and to have underrepresented minority counselors who actually better meet with some of our students. And so we've tried to be very thoughtful about what resources we do provide. I think the other part has been the more structural. So going back to the conversation around, we come full circle, around learning environment, one of the approaches we have tried to take is, how can we remove any unnecessary stressor? So are there things in the environment, in our system, in our grading, in our overall approach that are creating extra stress that we don't need? And so we just made a pretty big structural change to our first year for this coming year, because the way we had it was we had a 12-week block, 8 weeks that were before the winter holidays and 4 weeks after. And if you can think in the mind of a student, they're going to all feel like they have to study over the winter break, and they have since we implemented in 2013. We've heard every year, but it was a lot worse this year. And so we made a structural change to move that exam to before the winter holidays, because that was a stressor that the system put in there that really wasn't necessary for the sake of learning. Now, it's required a lot of logistical changes to new blocks and those things downstream, but it was the right thing to do, I think, for the sake of the mental health of our students. And so it was something that we felt really passionate about doing and doing now. But it's a mixture of having a lot of ways to pull data in to hear when they are struggling. So we have the coaches that meet with our students. We have college mentors. We sort our students into 4 colleges, kind of Harry Potter, Hogwarts style, if you're a Harry Potter fan. And so we've tried to build a lot of different ways to have feelers on the ground for our students struggling. If so, we want to quickly identify them and match them with resources, as well as then from a system standpoint, eliminating those unnecessary stressors. And so that really has been the approach we've taken. But I think it's important. There's always room to improve.
All right. Thank you again, Dr. Cutrer. So a virtual round of applause. Awesome talk to get us kicked off and ignited for what I hope and know will be an amazing day tomorrow. So with that, let me give you a little bit of insight about what to expect tomorrow.